مساء الخير عليكم جميعا. بنرحب بكم في المؤتمر ال 45 للمستشفيات جامعة عين شمس، وندعو الأستاذ دكتور محمد شوقي لإلقاء أول presentation في السيشن The Paradox of Technology Prevention or Acceleration of Cognitive Decline.
Good evening. I hope you will enjoy the lecture. I won't be long, but it's a paradox. So I was going to discuss the positive and the negative. Thank you very much for inviting me for this lecture, and thank you for the effort that you did for the organization. They did great effort, Dr. Aya and Dr. Manar. Thank you very much. Well, a typical introduction. Every 3 seconds, there is a new patient I'm going to move, okay? Every new second, there is a new patient for dementia worldwide. So from the beginning of my talk, there are 4 to 5 new patients have been added to the dementia. And we have a great challenge now, a great challenge that we are going to face in the future. The expected number of patients will be triple. It's a tsunami, dementia tsunami. Well, to make it in money, you can see that there is a huge burden, financial burden. Now the global expenses of dementia is 1.3 trillion and expect to be $2.8 trillion. The amount of dollars we all have in the whole world is not that much. It's about 100 trillion. So we are going to expend this, the amount of cash, I mean. So we're going to expend to pay a lot for dementia. And it's equivalent to the work of 67 million workers, full-time. And this is the curves, and the numbers are increasing. And prevention and need, it's possible. The number is increasing with time. Lancet Commission at 2017 said that 35% of the dementia cases will be preventable. This number increased to 2020 to 40%, and it has another increase for 24, and it was 45%. So near half of the cases of dementia can be prevented. Well, we have a lot of modifiable risk factors, 14 modifiable risk factors. And for us, the low to middle income country, we are expecting that we are the one who are going to get benefit, great benefit, because at our expected prevalence, we are expecting the dementia patient to be multiplied by 4, not by 3, like the rest of the world. So we are facing something stressful. Well, these are the pillars of brain health, the prevention. And we can see that technology can help us in the medical checkup, like we mentioned before in the conference, and it plays an important role in the mental fitness. And this is the rest of the pillars. So, what's cognitive resilience? It's our ability to stand the stress that we face, the age-related changes, the vascular incident that may happen to the brain. So, training our brain will increase our cognitive resilience, will increase our strategic cognitive reserve. So, it will play an important role in the prevention. How can we do this? We do this by the mental stimulation, of course, but it never be alone. We have to integrate it with a lot of things like the physical activities and social engagement and the healthy lifestyle. Well, is it that simple? I hope. We have a lot of challenges in dementia prevention. We have the lifestyle that we are adopting these days. We have the digital overload. We have the access to the preventive care. It's not that easy. And the social awareness education. It's 360 approach, and it is continuous approach. Well, what's the role of the technology? We are all expecting that there is a lot of cognitive training application. Who used cognitive training? Who tried cognitive application, training application? If somebody tried, please raise your hand. Thank you very much. Thank you very much. It's worked well, and it's adapt with the difficulties and improve the levels with using the applications. The wearable health tech. We have the step counts, right? The sleeping pattern. We can see our sleep. So using this technology will help us to adapt healthy behaviors. Of course, the role of AI in prevention, dementia, and early detection of dementia. Give the AI proper prompts, and it will give you proper or significant help. We have the telemedicine, and it's play an important role for prevention of dementia, of course. Well, this is a great benefit for technology, but it's a double-edged sword. Everything comes with a cost. So we all, of course, we are expecting that we have cognitive overload with using the technology. I used to face problems with excessive stimulation from the social media, right? It's not that easy to take rest using the social media or the technology. But usually we spend a lot of time at this application. And there is no need to say that this is the negative consequences of it. We all know it, of course. But there is another stressful condition. It's social and physical health impact. What we really use to do in this technology, it's decreasing the real life face-to-face. It decreases the real life face-to-face. It decreases the real life face. It's much better. It's decreased the real life face-to-face interaction. It takes time from our physical effort. It takes time to blend ourselves in front of the technology. We take improper positioning. Digital media overuse related to cognitive impairment. How we can relate this to cognitive impairment? The social isolation, the sleep disturbance, the cognitive overload, the reduced physical activities, excessive screen times. These play an important role in our health. We can translate it in these 4 points. What's the role of digital dementia? It's cognitive overload. Cognitive overload while our brain is passive. I'm not using my hippocampus that much. I'm passively receiving the information. And there is neuroinflammation. What's the relationship between neuroinflammation and technology? Technology definitely increases our stresses, right? And definitely, technology will play an important role to not to go out and do physical activity and watch your cytokines and neuroinflammation that increase your risk of atherosclerosis and increase your chronic low-grade inflammation, stress, or burden that you are facing. Definitely the circadian rhythm will be disrupted. What about the dopamine? Why you are using the technology that much? We all know the dopamine surge. Anything that we are used to addict, it's highly related to the dopamine in our body. Anything that you make us happy, it's usually associated with rise of the dopamine, increase the dopamine surge. Is it interesting to know that the whole issue of the technology is related to the use of excessive use of prolonged time you are going to use this technology. So what I'm expecting from a platform, whatever its name, with a huge investment and definitely creative minds, maybe hundreds of thousands of creative minds behind, and we are using this platform in a naive way. They are definitely well trained to make you attached to it, right? They usually play with your dopamine surge. But what's wrong with my dopamine surge? I'm getting happy. I'm having some increase in dopamine surge. Okay, in the real world, it's not natural. And even most of religion doesn't allow you to have this rise in dopamine because it's not normal. This rise in dopamine consumes your dopamine, so you're not going to be easily happy. You're not going to be enjoying the real life. In the past, we used to do physical effort to congratulate for the Eid, we usually go to the families and make physical effort to have some happiness, okay? And it's long-lasting happiness. But we usually don't face it now. We face the technology. We use the technology. So dopamine consumption is mimic the dopamine surge is mimic the addictive behaviors. We may have some blunt emotions, and of course, some decrease in our cognitive abilities. What else we can face with this technology? You know the FOMO, fear of missing out something? It's the fear that I'm missing a notification, I'm missing a news that I want to be updated. I'm getting used to the voice of this blogger or the voice of this entertainment. And of course, it's negatively affect our health. Definitely affecting our working memory and engaging with difficult activities. Do you know that nomophobia? I'm fearing that I will lose my mobile. I'm going to make a presentation, and without my notice, my mobile is still in my pocket. I want it beside me. It's give me a sense of security. It's give me the sense that I'm going to know everything whenever I want. And even it's a pleasure to drive with the GPS. It will drive me whenever I want. Yes, of course, it helped me a lot, and sometimes it messed my trip. But it decreased my visual spatial ability to find my way and to explore it by myself. And of course, it negatively affected the technology. So, what's your average screening time per day? Who measured the average screening time? Who wants to share? What the average screening time that we used? Our mobile. Who have the courage to say? 4 to 6 hours. Yes. 3 hours, perfect. My little son, when I criticize him, you are using the mobile from 2 hours per day to 8 hours per day. It's really swings, big swings. He said, oh, that the average is 5 hours per day. It's the average for normal person. I told him, okay, if use it 5 hours per day, if this bring you an investment, if this will add for your finance, use it 8 hours per day, but don't use it for joy for 8 hours per day. Actually, 4 hours per day has been linked to vascular dementia and Alzheimer dementia. And I'm really shocked for this, and the reference is here. And of course, we know that why. So, how to fill the gap? Of course, digital detox. Mind what we are using. Engage in real life engagement. Public awareness education. There is a lot of information, and we can easily search it, and we can easily find it over the AI. How to detox, and how to mindful the technology. Mindful everything we are doing is the best way to enjoy life. Mind what you are eat, mind what you are praying, what you are doing, exercise. Mind the cup of tea that you are drinking. You will definitely enjoy the real life. So, enhancement, real life engagement, of course. And public awareness and education. I would highly recommend ethical consideration, because we are a world that up till this moment we don't see positive regulation controlling the use of technology, and we are correlating this to the addiction. It is the same danger that cigarettes can have for our body, but in a different ways. Maybe cigarette more aggressive, maybe this technology may be more aggressive. We still need these points. A good understanding why people do not adapt healthy behavior in spite of knowledge. What we call the silent resistant. I'm silent, don't do what I want to do to improve my health. This is interesting paper. They found that technology definitely definitely add a lot of, for us, definitely had a lot of us. And definitely add to our knowledge. But the most interesting is this paper found that knowledge is not enough. It's easy to get the knowledge, but it's difficult to apply it. What's the real power in this? Is the meaningful and deep communication between us. Because if I'm within the proper environment, I will behave better. I will do better. If I only deal with my information, most probably I won't get the benefit from it. So the silent resistance is not due to ignorance of the knowledge, it's due to disconnection. And from my point of view, the real meaningful connection is the secret behind dementia or any other prevention, even the secret behind living healthy. If nearly half of the dementia patient can be preventable, we are as a geriatrician, what's our role in this? How can we make it reality? How we can use our brain, not just our screen. Thank you very much.
Thank you, Professor Mohammed Shawqi. Thank you, Professor Mohammed Shawqi, for this interesting lecture. Any question?
So it's very interesting, this paradox, and I think we can all relate. So when I'm watching a YouTube video that's related to work, I feel comfortable. But when I'm watching a movie or a Facebook reel, then my conscience starts hurting. So it's very difficult, and I think it's not just, the mindfulness is very important, but still we have to limit, as you said, the screen time, whatever we are doing, even if it's work. Now, my question is, we have been suggesting for time and time cognitive rehabilitation using technology. We have been using it for decreasing behavioral symptoms in elderly, like the VR videos and so on. Are there studies that say that using this makes the decline in cognitive functions faster? And will it be cost-benefit-wise? I'm decreasing the behavioral symptoms, so what if it's proceeding quickly? So I think this is even a more difficult ethical paradox that I'm not sure how to proceed with.
Thank you for this question. Yes, definitely. Using the cognitive stimulation or rehabilitation application will add to our cognitive reserve and will increase our cognitive resilience. But how we can dissociate this from the FOMO, the fear of missing something? How to resist? How differentiate between the time I'm going to train my brain and the time using the application, extra time that I'm using the application. Yes, it's really a challenge. And you have a great point. We have to be mindful how to use it. Use the technology in the best way you can. There is a lot of techniques, of course, we can get away from this technology. But still, the main message is do it with somebody else. Do it with meaningful connection, with social connection. Thank you very much for the question.
Thank you, Professor Mohammed Shawqi. I want to invite our next speaker, Assistant Professor Dr. Heba Tawfiq, Cognitive Rehabilitation in Dementia, where we are and what we can do.
السلام عليكم. سعيدة بوجودي النهارده في المؤتمر. I will talk in Arabic and English for better illustration. I will talk about cognitive rehabilitation in dementia. علاقة التكنولوجي والتقدم السمارت بالcognitive rehabilitation. Okay. We have for persons or people living with dementia journey. Dementia journey differs from patient perspective than doctor perspective. هنا ده البيشنت برسبكتيف مريض الديمنشيا مختلف طبعا خالص عن الدكتور برسبكتيف. بعد ما احنا بنشخصه الدايجنوزس المهم بالنسبه له السنس اوف diagnosis. What does this mean? What is my plan? Advanced directives. How to connect with community services. هل اقدر اكمل driving ولا لا؟ My care partner will be with me or not? Can we have all services at home or not? انا ممكن ابقى سيف في الانفايرمنت بتاعتي، انا هفضل مكمل، هتفضل الناس اللي بتحبني حواليا، ولا انا هروح اعيش في نيرسينج هوم. This is different from doctor perspective a lot about diagnosis and treatment options, pharmacotherapy, treatment comorbid conditions, non-pharmacological intervention connected to the person, living at home or at nursing home and so on, and end of life care. Okay, we'll talk about cognitive rehabilitation. What is cognitive rehabilitation? NICE guidelines in 2018 recommends that we can consider cognitive rehabilitation or occupational therapy to support functional ability in people with mild to moderate dementia, and offer cognitive stimulation, and does not recommend cognitive training for people with dementia. Okay, so we perform cognitive training for people with subjective cognitive decline and MCI and the dementia stages. We offer cognitive stimulation and cognitive rehabilitation. طب هو ايه الكوجنيتيف ريهابيليتيشن اساسا؟ cognitive rehabilitation ايه الهدف من الكوجنيتيف ريهابيليتيشن؟ اهم حاجه ان احنا نحط functional goals. اوكي طيب الجولز بتاعتي ايه اصلا؟ الجولز بتاعتي الكواليتي اوف لايف بتاعت البيشنت، الفانكشن بتاع البيشنت. اوكي this is the main perspective. Our perspective in cognitive rehabilitation improving or maintaining functioning في everyday life. هي الفكره ان انا اقدر اساعده ان هو يقدر يعمل الفانكشن of daily life، يقدر يعملها قدر الامكان لوحده، يقدر يبقى independent. اوكي ما يحتاجش للناس اللي حواليه قدر الامكان، احسن الكواليتي اوف لايف بتاعته. في نقطة مهمة ان انا بعمل له ري ليرنينج ازاي يقدر يعمل الاكتيفيتيز بتاعته، وفي نفس مش هدفي ان انا احسن الكوجنيشن، هدفي ان انا اخليه يقدر يحسن الفانكشن. تمام، اقدر امنتين الديلي اكتيفيتيز، ده الهدف الاساسي، واقدر اعمل كومبنسيشن للديسابيليتيز اللي عنده، كومبنسيشن للكوجنيتيف بروبلمز اللي عنده، اقدر اقوي السترينثز اللي عنده. تمام، يبقى الهدف ان هو يبقى قدر الامكان اندبندنت، الفانكشنز تتحسن، الكواليتي اوف لايف بتاعته تتحسن. Okay, another term referred to cognitive rehabilitation is reablement. Okay, relearning of doing activities. Cognitive rehabilitation address the person, the context, the activity. اوكي يبقى انا عندي 3 محاور بشتغل عليها، الشخص نفسه وازاي الكوجنيتيف ريهابيليتيشن يبقى تailored للشخص نفسه، الكونتكست، الكير جيفر اند environment. how environment can be safe for this patient. اوكي ازاي الانفايرمنت ممكن تبقى مناسبه ليه. الكير جيفر education about the disease and how to deal with the patient, how to deal with the disabilities and problems of the patient, and how to decrease caregiver stress. دكتوره نور هتتكلم بالتفصيل عن الكلام ده، عن الكير جيفر، الستريس والهيلث education وعلاقته بالتيليميديسن. الجزء الثالث هو الاكتيفيتي. اوكي smart solutions in dementia. We have various solutions, but there's no evidence base till now, no guidelines till now. All our studies, randomized studies, and systemic reviews, and so on. I'll mention this. There's smart assistive devices like smart home systems, including Alexa, and we talk about it, wearables, smart watches, and smart socks, and so on, to track sleep, movement, heart rate variability, and oxygen and temperature, and GPS trackers for especially important for people for wandering and so on. Virtual reality and augmented reality platforms are now available. Robots are now available, and various types of robots, social robots, humanized robots, pet robots, and nursing robots. We will talk about them. There are smart cognitive rehabilitation platforms and smart monitoring system. طيب ايه المشكله في كل الكلام ده؟ طبعا في مشاكل كتير في السمارت تكنولوجي. كتير ستاديز بتتكلم ان السمارت تكنولوجي هي بتخلي الشخص باسيف. هي الفكره ان انا بحاول اعمل له كومبنسيشن، هو ده جزء من اهداف الكوجنيتيف ريهاب ولكنه مش الهدف الوحيد. فانا بحاول اعمل مونيتورنج للشخص، بعمل كومبنسيشن لبعض الحاجات، ولكن مش بساعده ازاي يحسن الاكتيفيتيز بتاعته، مش بساعده يحسن الفانكشنز. عشان كده ابتدى يبقى فيه دلوقتي ستاديز كتير وفي بروجكتس بتتعمل ازاي ممكن نساعده ان احنا نحسن الفانكشن. السمارت سبيكر ديفايس في ريهابيليتيشن زي الجوجل هوم، زي الامازون ايكو ومنها الاليكسا، يعني اللي هي الارتفيشال انتليجنس. طبعا في منها جنريشنز كتير، حوالي تقريبا 5 جنريشنز. ممكن سبورت زي people living with dementia، ممكن تسيت reminders alarms to do list، ممكن to remind patient to take medications. Okay. And remember the time and date and so on. Can act as like home automation hub, can order a meal, can play music, can order Uber. Robots in dementia, there are nursing robots. Nursing robots can improve physical activity also, can play music, okay, can do reminiscence therapy, and this is very important. Social robots can monitor restlessness and agitations and behavioral problems. Many tools now in smart technology and telemedicine and so on are focusing on improving behavioral problems with dementia. Okay, how to improve behavioral problems with dementia. And there are pet robots and humanized robots and so on. This is a systemic review and meta-analysis of about 15 studies reporting if intelligent robot interventions benefit people with dementia or not. هم بيتكلموا، هم جمعوا تقريبا حوالي 15 study بتتكلم هل الروبوتس فرقت في عيانين الديمنشيا، هل اتحسن الكوجنيشن بتاعهم، هل الفانكشن بتاعتهم اتحسنت. لكن هم لقوا ان الروبوتس اللي بتستخدم حتى الان قللت البيهيفيرال بروبلمز، حسنت الانكزايتي بتاعت البيشنتس، ولكن ما اثرتش في الكوجنيشن، يعني ما عملتش سلو، ما قللتش الديتوريشن بتاع الكوجنيشن ولا حسنت الدبريشن. الفي ار، الفيرتشوال رياليتي اند اوجمانتد رياليتي، هم دول دلوقتي بيحاولوا قدر الامكان ان هم مش بس يحسنوا البيهيفيرال بروبلمز، بيحاولوا يحسنوا الديلي فانكشنز بتاعه البيشنت. ازاي ممكن يساعدوه يحسن الديلي فانكشن؟ تمام. الفي ار بيست، there are VR based reminiscence therapy. اوكي. VR based multi sensory stimulation. دلوقتي في تكنيكس مختلفه للفيرتشوال رياليتي، ان هو ممكن طبعا عن طريق السيستم بقى بتاعها والنظارات وكده، ممكن يعيشوه في نفس الجو اللي هو مثلا كان بيعيشه، نفس الاكتيفيتي اللي كان بيعيشها، الاماكن اللي كان بيحب يروحها، زي مثلا كان بيحب يروح جاردنز، بيبقى فيه سيميوليشن مثلا الاماكن بتاعت الشغل بتاعته. اوكي. فده يعتبر زي ريمينيسنس ثيرابي. وفي كمان مالتي سنسوري ستيميوليشن، ده برضو دخل في الفيرتشوال رياليتي، بيحاولوا ان هم من الحاجات اللي بيطبقوها دلوقتي. طيب البروبلمز بتاعت الفيرتشوال رياليتي، طبعا بروبلمز بتاعت الكوست، بروبلمز تكنيكاليتي، applicability for dementia patients، هل ده applicable ولا لا؟ يعني الديمنشيا هيقدروا يتقبلوه يتعاملوا معاه ويستخدموه، مش هيتعبوا منه اساسا. الفاتيج والديسنس والموشن ثيكنس اللي ممكن تحصل، والكلام ده بيحاولوا يتغلبوا عليه بالتايب بتاع الفيرتشوال رياليتي بروجرامز دلوقتي، لان هي منها كذا تايب اساسا. وفي تايبس لو انها ناجحه في الاطفال فممكن تنجح في الالدرلي بوبيوليشن وفي الديمنشيا patients. وطبعا lack of standardization، كل الحاجات بتاعت التكنولوجي مفيش عندنا حاجه ستاندردايز تقول ده هيتعمل هنا وهنا 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 وهكذا. طيب يبقى برضو الفيرتشوال رياليتي هتساعدني ان انا البيهيفير يتحسن. اوكي. ريمينيسنس ثيرابي ممكن تحسن البيهيفير، تقلل الانكزايتي، الكلام ده ممكن يحسن الميموري او لا ممكن. ابتدوا يفكروا في الفيرتشوال رياليتي والاوجمانتد رياليتي انها ممكن تبقى فيها يعني اوري البيشنت ستيبس ازاي يعمل الاكتيفيتيز بتاعت الديلي ليفنج. تمام. ازاي مثلا يعمل الحاجات البسيطه اللي المطلوب يتعمل، يعني عايز يعملها ديلي، مثلا ازاي يغسل سنانه، ازاي يعمل كوبايه شاي وهكذا. بيحاولوا ان هم يعملوا الكلام ده خاصه بالاوجمانتد رياليتي، لان الاوجمانتد رياليتي مرتبط اكتر بالواقع. هو الحاجات اللي موجوده عنده في الواقع هو هيشوفها، ولكن هو ممكن يعرفه مثلا لما يلبس الجلاس بتاعتها، يعرفوا مثلا اسماء الحاجات اللي هو ما كانش عارفها. اوكي. ممكن يشرح له حاجات بسيطه، ازاي مثلا ممكن تعمل حاجه صغيره، ممكن تعمل مثلا ميل صغيره، يعرفوا الاماكن في البيت، كل مكان يبقى بيشاور عليه. اوكي. يعني يبقى المكان يبقى صاين بحيث ان هو ما يتلخبطش في الاماكن. This is a game console designed for healthcare settings. ده بروجرام سمارت تكنولوجي بروجرام لحد ما داخل فيه جزء فيرتشوال رياليتي. هي عباره عن جيم فيها بروجيكتور فيها تيبل، والتيبل دي عليها بروجرامز تailored according للبيشنت. هي ممكن بقى يختار البروجرام المناسبه ليه، البروجرام اللي ممكن تفيده. وبتقلل جامد جدا الانكزايتي. هم لقوا انها في ستاديز كتير بتقلل الانكزايتي وبتقلل behavioral بروبلمز. هي الفكره بتاعتها بايه؟ هي طلعت في نيذرلاندز في هولندا، وانتشرت في دول كتير قوي، في بلجيكا وفي يوكي وايرلاند وجيرماني وكده. لو احنا اخترنا البروجرام، احنا ممكن نختار مثلا بروجرام ان احنا هنعمل وصفه، تمام، وهو بيبتدي، هي صور بتظهر له، هو لما يبتدي يدوس عليها ويحركها تبتدي الوصفه تتكون. يعني اكون مثلا عجينه، هحط ميه، هحط دقيق، الكلام ده بيتعمل على التيبل. يعني المكونات دي هو مجرد بالتاتش، الحاجات دي ممكن نضيفها على بعضها. فهي الفكره انها حاجه انترتينمنت، وفي نفس الوقت ممكن تفكروا بالخطوات بتاعه انجاز الاشياء الصغيره. ممكن يشوف ورد صغير، ورده لسه صغيره مقفله، ممكن تبتدي تتفتح وتكبر وهكذا. فده ممكن يحسن الموتور اكتيفيتي، وممكن يحسن شويه الميموري بتاعت البيشنت. التوفرتافل الستاديز اللي اتعملت عليها لقوا انها ممكن تحسن الكواليتي اوف لايف، تحسن الاباثي، فيزيكال اكتيفيتي، الموتور فانكشنز، بوزيتيف ايموشنز، تقلل الريستلسنس وتقلل تنس بيهيفير. اوكي، وتحسن الريليشن شيب ما بين البيشنت وما بين الكير جيفر او الهيلث كير وركر. These devices are for monitoring. دي سمارت كلوزز، ده بروجكت اتعمل في مصر من حوالي 5 سنين. كان 3 بنات عاملينه في مشروع التخرج بتاعهم في كليه فنون تطبيقيه. دي سمارت ديفايسز بتتحط في الملابس، هم عملوها للالدرلي بوبيوليشن وللناس البلايند وللناس الديمنشيا. الهدف منها ايه؟ انها GPS تراكر، بتديتكت الاوبستكلز اللي قدام البيشنت، بتديتكت الانستيدنس، بتميجر الاكسجين والتمبريتشر، وفي نفس الوقت كمان بتريكورد الكوموربيدز. دي سمارت سوكس اتعملت في لندن. السمارت سوكس دي برضو زي سنسورز بتبقى متركبه في السوكس، بتديتكت البالس ريت والبالس ريت فاريابيليتي والتمبريتشر والاكتوديرمال اكتيفيتي. هم لو الاكتوديرمال اكتيفيتي بتزيد لو في اجيتيشن او ريستلسنس، فممكن تديتكت من بدري لو في اجيتيشن او ريستلسنس. بس لو ان في بروبلم ان الاكتوديرمال اكتيفيتي برضو ممكن تزيد لو في هابينس. فهي الفكره ان انا ممكن يبقى الشخص سعيد لسبب ما كان سعيد او فرحان، وتتفسر على ان هو خايف او عنده اجيتيشن او ريستلسنس. عشان كده دي برضو من البروبلمز بتاعه السمارت تكنولوجي، ان احنا ما ينفعش نعتمد عليها لوحدها، لان دور الدكتور مهم جدا. Smart homes for detecting dementia. There's radar Alzheimer's disease project. This was funded by Europe Alzheimer. ده بروجكت اتعمل في اليونان، وهيبتدوا يطبقوه في اماكن تانية، واتعمل له ويب سايت. الهدف ان هم جابوا عدد من الاشخاص، جابوا حوالي 40 شخص، وعملوا لهم كوجنيتيف اسسمنت قبل ما يقعدوا في السمارت هومز، وقسموهم لناس نورمال وناس سبجكتيف كوجنيتيف ديكلاين وناس مايلد كوجنيتيف امبيرمنت، وقعدوهم في السمارت هوم وطلبوا منهم يعملوا اكتيفيتيز معينه، تمام. وعن طريق السمارت تكنولوجي ابتدوا يتابعوهم ويراقبوهم، يشوفوا اذا كان هم هيقدروا يحددوا من الوقت اللي هم بياخدوه، من الستبس اللي بيعملوها، اذا كانوا بيعملوا ستبس زياده، اذا كانوا بيعملوا ستبس غلط، اذا كانوا بياخدوا وقت طويل جدا، هيقدروا يحددوا اذا كان عندهم مشكله في الكوجنيشن ولا لا. ولقوا ان هم فعلا بنسبه كبيره، بنسبه 70 او 80% قدروا يقسموا فعلا الناس زي ما كانوا مقسمينهم بالكوجنيتيف اسسمنت قبل كده. كان حد عنده MCI او سبجكتيف كوجنيتيف ديكلاين او كده، خد وقت اطول، عمل خطوات زياده، ما عملش خطوات المفروض كانت تتعمل، وهكذا. اوكي. The future of AI and smart technology in dementia. They are finding approaches to prevent dementia, predict and early detect dementia through analyzing language of the patient, genetics, brain imaging, biomarkers, and EEG. Developing algorithms for cognitive stimulation rehabilitation programs for improving cognition, motor, and daily functions and quality of life, especially by VR and AR. Problems طبعا انا اتكلمت على problems كتير من شويه، بس برضو زياده عليها lack of transparency، لو في errors حصلت، excessive trust in technology and data protection and ethical issues. دي سمارت سيتيز اوف 2024 شنزن في الصين هي تم اختيارها السيستم كله عندهم سمارت انها السمارت سيتي في 2024 في شهر نوفمبر. ده الكوجنيتيف تريننج لاب عندنا في عين شمس. طبعا احنا نتمنى الناس تشرفنا نعمل تريننج سيشنز للناس سبجكتيف كوجنيتيف ديكلاين والام سي اي عشان نبريفنت الديمنشيا اصلا. ثانك يو.
Thank you, Dr. Heba, for this interesting lecture. Any question for Heba?
هبه انا كنت عايزه يعني اسال بالنسبه للفيرتشوال رياليتي فور patients with dementia ما اعرفش احساسي الشخصي يعني ان هي هتبقى more confusing for the patient hard to operate ممكن يعني ممكن تزود عند العيان الاجيتيشن actually لان هو انا بنقله من one environment to the other وهو مش مستوعب. فهل الكلام ده مثلا applicable في ال early stages of dementia ولا في ال late stages؟
اوكي هي الستاديز كلها بتتكلم على الايرلي ستيجز المايلد ديمنشيا او المايلد تو مودريت ديمنشيا لكن مفيش حاجه واضحه في الفيرتشوال رياليتي اللي ستيجز الصراحه وفي نفس الوقت هم بيتكلموا برضو في ستاديز اتعملت نشرت في فرونتيرز ان هم هي الفيرتشوال رياليتي اساسا انواع في منها نون اميرسيف وسيمي اميرسيف وفولي اميرسيف على حسب احنا بنندمج قد ايه مع الفيرتشوال رياليتي تمام مع التكنولوجي نفسها هل هيندمج كامله او يعني فيها ليها تكنيكس كتير ومعقده قوي. فهم في ستاديز عمل لقوا ان الاطفال الناس اللي عندها ديفلوبمنتال بروبلمز الاطفال اللي عندهم مشاكل كانت بالنسبه لهم السيمي اميرسيف الى حد ما سهله وقادرين يتاقلموا معاها فهم شايفين ده ممكن يبقى ابليكابل الى حد ما للايردرلي والناس الديمنشيا في الايرلي ستيجز. هم في انواع معينه في الفيرتشوال رياليتي هي اللي ممكن يطبقوها وفي ستيجز في الاول مش كله طبعا.
شكرا. Actually, Heba, do you remember the pilot that we had with the VR? We had a pilot for our patients, the VR at the outpatient clinics. But at the time, there wasn't a lot of options of the VR headsets. And they played two games. One of them was diving inside the sea and playing with the fish and everything. And another was like the Fruit Ninja. And the pilot was done for two things. First of all, acceptance, because we were not sure if the patients coming to Ain Shams University were fit and accepting using VR headsets. They look like the sci-fi movies, so it's something very different from what they were used to. And the second thing was the motion sickness, because if you're totally immersed, you get the motion sickness, and it's related both the immersion, as Dr. Heba was saying, and the time of usage. Now, of course, the Microsoft VR sets, you can see the surroundings also, so the motion sickness doesn't happen that much. But actually, they were very happy. Everyone was going outside of the clinics with a smile on their face. It was really amazing. We just didn't have the time to publish this paper, but it was a really good finding that I really like to share with everyone. Thank you.
Any other questions? And now we invite Dr. Heba Saber, Associate Professor of Geriatrics, to give us a brief about being smart about dementia.
مساء الخير جميعا. I'm very honored to be here today to give you this short and hopefully sweet lecture about being smart about dementia. I will try not to be repetitive because Dr. Muhammad has already touched on some of the things we're going to talk about, as well as Dr. Heba Tawfiq. First of all, why are we so concerned about dementia? We have to remember that 131.5 million people will be living with dementia by the year 2050, which is quite a substantial number. And To put it into more perspective, we don't know that much about dementia as doctors, as clinicians, as researchers. And this insecurity has become translated to the public. 2 out of 3 people find that there is little or no understanding of dementia. I'm talking about our patients, people in the community. And as Dr. Muhammad said, every 3 seconds, someone will be diagnosed with dementia. So if this is a 20-minute lecture, if you can do the math, how many people will actually have been diagnosed or developed dementia by the time I finish? And when we talk about dementia, we always think about Alzheimer's disease. We forget that dementia is an umbrella term. It includes many different kinds of dementia. I would like to stress on vascular dementias, especially in our countries and developing nations where the burden of chronic disease is quite high and we still have problems with cardiovascular risk factors. So vascular dementia is quite burdensome to us. And we also have to remember that dementia can also be mixed, and it's not just Alzheimer's and vascular, it can be several other types of dementias mixed together. So we're dealing with a disease which can have many different clinical forms. It's not always easy to diagnose. So should we be smart when we try to diagnose and deal with dementia? And what is the role of smart technology and using AI in healthcare for our patients? Smart technology is different to artificial intelligence. هما مش حاجة واحدة ولا هما interchangeable. أنا ما أقدرش أقول على artificial intelligence هو smart technology والعكس. Smart technology gives me the tools to process and collect information about the disease, while artificial intelligence will help us actually analyze the feedback that we get from smart technology. So another way to think about it is that when we use smart technology like wearables and sensors, they are هم اللي بيستقبلوا المعلومة ويدوهاني. They are my eyes and my ears, but they're not my brain. The brain is artificial intelligence. Artificial intelligence in general is the overall idea. The first step with artificial intelligence was machine learning. And please remember that machine learning, the machine did not learn on its own. إحنا اللي علمنا الجهاز، إحنا اللي ادينا له input، إحنا اللي ادينا له information و algorithms. And according to the information that we give the machine, it processes information and gives us an end result, an output. That is what we're used to using. The next phase, the most recent phase, is deep learning. Deep learning tries to mimic how the brain works. You can use multiple inputs at the same time and they can be processed at many different levels to reach an output at the end. يعني هو الديب learning بيحاول يفكر زي المخ، يستقبل معلومات كتير، يعمل لها processing ويطلع لي بكذا outcome. The idea is that in the presence of artificial intelligence, healthcare should be better. So how can we use smart technology and artificial intelligence to help our dementia patients? It's quite a journey. It begins with prevention and screening, all the way to living with dementia in the end. To begin with prevention. In an ideal world, when we try to diagnose dementia, we always recommend our patients do some sort of neuroimaging, whether it's a CT or an MRI. And if it's available, we can also use a PET scan. But is it always easy to analyze the images that we get? Do we have to wait long times for someone to give us a feedback or reports? We try to take a look ourselves at the images and determine what we see. But it's not always easy, it's time consuming, and we're not always accurate. So the first thing that they thought about is, why don't we use automated analysis of MRI and PET scans so that we can pick up these details a lot easier and quicker and more accurately? There are many neuroimaging modalities. We're used to looking for structural abnormalities. We can look for metabolic changes and look for specific pathologies. في دلوقتي حاجات markers كتير بنستعملها. ممكن نشوف البروتين aggregation، ممكن نشوف الجلوكوز activity، ممكن نعمل functional MRI. كل دي data كتير جدا which can be lost if we try to pick it up as clinicians. It's time consuming, it delays diagnosis. So maybe using AI will help us make it faster, efficient. At the same time زي ما أنا قلت هيساعدني إن أنا ألقط حاجات صغيرة أنا ممكن ما أشوفهاش. One of the pathologies اللي إحنا مش متعودين ندور عليها المايكروبليدز. Microbleeds دي بتتشاف في cerebral amyloid angiopathy, and it's also a major risk factor for dementia. And with the newer treatments that are available, الantibody based therapy إحنا لسه ما استعملناهوش, we're not used to it, But one of the main side effects that it causes is microbleeds, something that is called ARIAs, or amyloid-related imaging abnormalities. Patients who use antibody targeting therapy are screened for this. They have routine MRI scans to look for ARIAs. And when they develop, they give them actually steroids so that they can stop their development. So these are just part of the things that we can detect with AI when we're using imaging techniques. During cognitive assessment, we can be simple or we can be sophisticated when we're using technology for cognitive assessment. We can be simple, I'll just skip this slide and come back to it. There are some very old tools in Cambridge, I think they have the CanTab battery. It's a tablet-based cognitive assessment. It's not fancy. The patient uses a tablet to perform a pencil and paper test. There are other computerized tests. These are the simplest versions of using technology. So simply, we're giving them a tablet so that they can do the test at their own will without my interference. But if we want to be more sophisticated, there was a study done in Singapore where they developed a tool called Recognize. It uses neuroscientific games to identify the early signs of cognitive impairment in just 15 minutes. أكيد لو أنا بلعب جيم بالنسبة للعيان ده أسهل له كتير من أنا أقعد أسأله أسئلة كتيرة و very detailed وساعات it can be embarrassing to the patient when I ask them simple questions in front of their family. But if they're using something like this, it might be easier, maybe more acceptable. So during cognitive assessment, we can use AI-powered tests. They can give us the analysis and the feedback when we use the test. We can use digital biomarkers to see. And we can also try to monitor them at home. And we'll go into more detail. When we talk about biomarkers by definition, معلش ما تضحكوش عليا بس أنا بسمع كلمة biomarker بحس إن هي تبقى حاجة يعني فظيعة وحاجة رهيبة. But actually, biomarker is anything that we can measure. Any measurable which dictates or tells me something more about a biological or a pathological process going on in the body. So it can be something على فكرة as simple as taking temperature. That's a biomarker. Or it can be something more sophisticated, like using a sensor at home and telling me that there are changes in my patient's gait, indicating that maybe cognitive impairment is on the way. So biomarkers can be many different things. They can be neuroimaging زي ما اتكلمنا قبل كده. ممكن أعمل electrophysiological studies أشوف لو في أي changes في البرين waves. ممكن أبص على gene expression هل هم they have something hereditary, something is coming. أبص على different proteins, أبص على different metabolites. Gut microbials will changes في gut microbiome حاجة مهملة شوية بس ممكن منها نبتدي predict ال cognitive frailty و cognitive impairment بعد كده. أبص على السليب، أبص على الجيت، أشوف other digital biomarkers هنتكلم عنها والدكتورة هبة ادت معناها فكرة. We can look at the CSF and see if we can find amyloid protein, tau proteins. But the next step is not just trying to find it in the CSF, it's also trying to find it in the blood, in the saliva, and even tears in urine. So maybe if we can have access, easier things, more acceptable to our patients to look for different markers, that might be more helpful. Regarding digital biomarkers, they can be something as simple as something portable like a tablet or a smartphone or a wearable. It can be something implantable, digestibles for measuring the changes in the gut microbiome, or something passive, something that sensors that we place in the home or in the car. All of these sensors aim to give me feedback on biological things like their blood glucose, even serum sodium, anatomical changes or physiological changes, changes in the heart rate, in the gait, in how they walk. All of these parameters can be put into an algorithm and give me an output at the end of the day. احنا لحد دلوقتي قلنا معلومات كتير قوي وحاجات كتير قوي هنقيسها وهنشوفها ومش عارفين نعمل بيها ايه، صح؟ ماشي، المفروض ان انا when I'm using بقى artificial intelligence هو اللي هيقول لي هعمل بيها ايه، كل المعلومات دي. دكتورة هبة كلمتنا عن smart homes. Using a smart home is a very good idea. There might be some ethical issues about invasion of privacy بس هنرجع لها في الآخر. Using a smart home will help me observe my patient in their natural environment, not in the clinic, not in an office, not with a pencil and paper in front of their family and asking them questions that they might find simplistic or embarrassing. They're at home, they're in their environment, and I can get feedback on how well they manage at home with sensors. Has their gait speed been affected? Is there any instability? Is there any abnormal movement during the home? Do they have problems with their sleep? All of this in the comfort of their own home. So this is real life. monitoring and assessment of cognitive abilities. Many dementia patients drive وفي مصر عندنا عادي هو العيان اتشخص الزهايمر ودخل في المودريت وممكن كمان اكتر من كده وماشي بالعربيه والمفاتيح ومحدش عارف يفرمله لكن لو انا في سيستم احسن شويه هنقول ان المايل dementia patient might still be driving even in developed countries. Well, how do we know that they've begun to develop dementia? Well, if I have an in-car sensor, I can see how they drive. In early stages of dementia or the beginnings of cognitive impairment, I can expect my patient to be driving a little bit more slowly. They'll be less confident with driving, so they'll be driving for shorter distances, going to places that they go to frequently. They won't be adventurous with their driving and driving to fewer destinations. So an in-car sensor can tell me that these changes are going on with my patient. Wearable technology, I think if يعني لو سألت الناس كم واحد لابس سمارت واتش هنلاقي في ناس كتير لابسة سمارت watches. Lots of us are using smart watches now. We're used to step counters, but smart watches now can give us a lot more information. They can give us information about my heart rate. يعني my heart rate, blood oxygen. Some smart watches now can even give you a rough ECG. So there are lots of wearables with lots of information that we can get, and they're quite accessible with different costs from quite cheap ones to expensive and sophisticated ones. But we have to remember that anything wearable has to be acceptable to the patient. So it has to be personalized, it has to be unobtrusive. حد فاكر text book زمان بتاع cardiology when we're doing a stress ECG, patient running on a mill? How many devices were attached to that patient? A lot of devices. So that I could just get a feedback on how fast his heart is going during stress. Now I can do that with a watch. So it shouldn't be obtrusive. يعني ما يتكعبلش بيه وهو ماشي. حاجة سهلة يلبسها ويستعملها كل يوم. It should be intelligent. بمعنى it should be able to pick up good information. It should be sensitive and specific. It should integrate with other systems عشان أقدر أخد منه information أستعمله. It should be intuitive. It should be affordable. وأعتقد دلوقتي بقى في range للحاجات دي. This was a very interesting study done in Edinburgh. They were looking at the blood vessels at the back of the eyes, at the retina. Any early signs of atherosclerosis or changes in blood vessels might be an indication of the dementia to come, which is quite an easy way to assess for dementia. Fundus examination. They used artificial intelligence to analyze multiple images of multiple retinas of patients so that they would be able to detect these changes quite early on. And this was called NeurEye. And this is the actual professor who did the study. Why are we going to all this trouble? Why are we يعني بنصرف كتير و wearable technology و artificial intelligence وكلام كتير قوي. Why is it so important to detect dementia early on? المعلومة دي بتخضني كل ما بقولها إن إحنا عندنا preclinical phase محترم جدا up to 20 years before anyone will actually develop any symptoms. So it's worth looking into a screening method so that we can be able to pick up dementia a lot earlier on. Why do we want to do that? Maybe we'll be able to offer them in the future disease-modifying treatment. Maybe. We still don't have something standardized for that, but it should be on the way. It will help us identify target populations for trials of treatment. And at the same time, if we can anticipate dementia, we can help people live with dementia better when it actually comes. So just the numbers are quite shocking. 20 years before I developed dementia. 20 years, which means that during these 20 years, something very big is going to happen, and I don't know about it. And even when we begin to develop symptoms, I might stay up to 10 years in the MCI stage. So that's 30 wasted years if you think about it. How can technology help us with treatment? If we look at all of this input, all the input that we've got from smart devices, from artificial intelligence, it should help us at the end of the day reach something called personalized care or something called precision medicine. I should be treating the patient, not the disease. So any options I'm giving my patient should be tailored to their problems. If we're using artificial intelligence for prediction, for predictive analytics, it should help us predict how this person's disease will progress. How will their dementia journey look? It should help us also project what will happen in the future, how fast or how slow we think that cognitive impairment is going to develop for this person. It can help us identify high-risk individuals so that maybe we'll monitor them a little bit more closely. Maybe we'll be more aggressive with the interventions that we try to offer. It should also enable personalized care. As I said, we've got lots and lots of information. We're getting information from wearables, from blood tests, from many different biomarkers. And the aim of using artificial intelligence is to help us process this information so that at the end of the day, we can reach some عناوين كبيرة, large things that we can process or use as clinicians, whether it's confirming the disease and the stage, whether it's being able to offer them something personalized, and also at the same time, recognizing my patient's prognosis. With research, well, research, I think one of the big breakthroughs of research using artificial intelligence is not just processing information, it's actually during drug discovery. The problem of developing drugs for dementia is at the same time we still aren't particularly sure about the pathology that's going on, and at the same time it's expensive, the patients are vulnerable. There are many ethical considerations when you're using drug trials for a dementia patient. Things like consent and approvals. But if we can use artificial intelligence to help us predict how a drug might work, help us predict the side effects of the drug when we use it, it helps us also predict which populations or which type of patient will benefit more from this drug, one from the other. So when I set up a clinical trial, I'll be more targeted. I'll be using specific patient groups, not looking for a very large subgroup. How about living with dementia? How do we think that technology can help us living with dementia? Obviously, sensors and wearables will give us very good feedback about my patient within the environment that they live in. It might make their caregivers feel a lot more safer about leaving them within their environment, helping them to be more independent. But one study was looking at chatbots. Chatbots احنا أقرب حاجة عندنا كل واحد في التليفون بتاعه يا في سيري يا في أليكسا يا في حد بيكلمنا. This is a chatbot. أما بكلم حد على فيسبوك ماسنجر بسأله على سعر الشنطة دي بكام، عادة اللي بيرد عليه automated message which is also a chatbot. دي algorithms هم بيدخلوا جواها data وبيخرجوا منها acceptable responses. فأول حاجة أنا حسيت بيها companionship and social interaction. When I'm talking to a chatbot, this is some sort of socialization. In a society يعني مش إحنا دوشة، إحنا مصريين، إحنا رغايين وبنتكلم كلنا كتير مع بعض. Like in other societies where elderly are more isolated, this can offer a very good option for feeling less isolated and more, let's say, comfortable with being alone. When I feel that there's a human voice at the end of the line, it can help with cognitive stimulation. They can offer exercises and games and chat with people and help them go through these and give them instructions at the same time. As Dr. Heba said, also we can use it for reminiscence therapy. What else can they do? They can help elderly people with dementia with their activities of daily living, providing them reminders for appointments, for medications. Dr. Heba also said that they can use VR to prompt them through daily things that we do, like brushing their teeth, like drinking a cup of tea. Caregivers will feel a lot more comfortable, as I said, knowing that they can get feedback about their loved one at any time of the day. And at the same time, they can use chatbots to gain information about their patient and how to help them more. We've almost finished. This was an experiment, or actually a model done in Russia, where they used a chatbot with elderly. كان أكتر إن هو برنامج بيتكلموا معاهم عامل زي ال personal assistant بس for the dementia patient. يعني there is some sort of social interaction. It helps them with their medications. It helps them manage their day. Other applications of using artificial intelligence might include in the future using robotic caregivers for dementia patients. دايما نفتكر ان هدفي مع المريض بتاعي ان هو يقعد اطول وقت ممكن as independent as possible، يعني في environment لوحده من غير ما اضطر ان انا اتدخل او اوديه مكان مخصوص. فوالله لو في robotic caregiver ممكن، فكره مش وحشه، بس مش عارفه الديمنشيا patient هيتعامل معاه ازاي. حاجه تانية بس ده في النيرسينج هومز اكتر is the remote monitoring of dementia patients. زي ما انتوا ده برنامج this was developed in Japan where they could monitor the movements of their patients in the individual rooms without actually having to every now and again come in and check on them. They could see where their patient was, they could see if they were in trouble, or maybe if someone fell. Are there ethical issues in using artificial intelligence, or in general looking for something to screen dementia with. زمان في الكوميونتي كده كان في جدول كنا بنحفظه كده. ايه هو screenable disease؟ تمام؟ Can we apply this to dementia so far? Maybe not. We still don't have an acceptable prodromal phase. We still don't have acceptable screening measures. We still don't have a generalizable treatment. So maybe it's not as applicable as we think it is, but it is important to us, and that's why we keep talking about prevention and screening, even though maybe public health-wise it's not as applicable as we think. At the end of the day, is it something good or something bad? Dr. Muhammad told us about the paradox of using technology. So there's a good side and there's a bad side. One of the good sides is that maybe we'll be able to reach more patients and offer them more solutions. Maybe we'll be able to screen earlier on. The bad side is some people say that when we're using technology, it lacks human empathy, it lacks human interaction. أنا عن نفسي عايزة أقول حاجة. At the end of the day, when we're dealing with technology and dealing with dementia patients, we're looking at our patients right now. I'm in my 40s, my patient might be in their 70s. When they were younger, they didn't have technology. But one day I will be in my 70s. One day the generations around us will grow old. They are a lot more used to using technology than we are. So maybe the barrier is in our minds, that we're afraid of using technology because we think it might be alien to older generations. But there are older generations coming who are used to using this technology. Yes, thank you very much.
Thank you, Dr. Heba, for this detailed presentation. معلش استاذنكم نخلي الاسئله في الاخر لو في اي اسئله. دلوقتي هتقدم لنا توك بعنوان The Health Outcomes of the Telegeriatrics Follow-up Model on Dementia Patients and Their Caregiver. دكتورة نور علي، اتفضلي.
Assalamu alaikum. Many thanks for invitation. It's time now to show the intersection between telegeriatrics and care of dementia patient in real practical way. Our session today about the health outcome of telegeriatrics follow-up model on dementia patients and their caregiver. First, I want to thank my team member, and it was a great pleasure to work under their supervision. Professor Dr. Sarah Ahmed Hamza, Professor Dr. Huda Farid, Professor Dr. Heba Youssef, we Assistant Professor Dr. Mohammed Fahmi Tolba. This agenda for my session today. As we all know, I want to repeat, dementia is a series of disorders characterized by deterioration of cognitive and function abilities. As Dr. Heba said, it is expected that more than 153 million will be demented cases in 2050. There are many aspects to care for this cognitive impairment, as we know. Healthcare provider may have limited time to devote it to each patient due to high patient volume. زحمة العيادة، عندي عدد كبير مش قادر أغطي كل وقت العيادة بتاعي إن أنا أدي healthcare sessions أو education. وكمان غير الادمنستريف tasks regarding multiple comorbidity، وده بيحتاج مني وقت أطول. This can make it difficult to provide comprehensive geriatric assessment for the patient, especially patient with cognitive impairment. Our patient in rural area have another magic problem. They have limited access to specialists who are trained in managing cognitive impairment. وده للأسف مش متاح all over Egypt. A primary care physician may not have the specialized training and experience needed to diagnose and manage cognitive effectively. one of the main complaint and the challenging in treatment of dementia, not only for the patient and his family, but also for the physicians. It was the psychiatric behavior, which is more frequent and are associated with excess morbidity and mortality and rapid disease progression. And nursing home placement, which increase the caregiver burden and increase healthcare costs. Our study here, not only for the patient, but also for the caregiver and family. Caring caregiver is considered, caregiving nafsu is considered a stressful condition, and it can lead to a high level of stress and burnout, as we know. And it was the most challenging manifestation of dementia or the behavior disturbances. What can telemedicine do, or how it can help me? Telehealth is defined as the use of communication technology to deliver health care at a distance, and the use of information via communication technology, which offers advantages including faster referral time, reduced clinical cancellation rate, and waiting time, hospitalization, and emergency department. التليميديسن استخدامه زاد اكتر، هو موجود من قبل كده بس its use increased magically during coronavirus disease pandemic and it was dramatically increased. It was anticipated that telemedicine will remain a frequently utilized modality for the patient encounter in the future, not only during pandemics. What about telemedicine and geriatrics? It was found that our patients are the better candidate for the telemedicine care than younger patients. It can help improving the access to care and bring specialized geriatrician care to them at home أو في النيرسينج هوم أو الريموت هوسبيتال أو الرورال اريا زي ما اتكلمنا قبل كده. It can provide a unique opportunity to learn about the patient living situation and environmental factors. Regards benefits of telemedicine, telemonitoring was widely used for enhancement of quality of life, decreasing mortality cost, and rates of hospital admission of different patients. Additionally, it was used for prevention and early diagnosis and treatment of chronic disease, especially in elderly. It also increased access to a specialty medical care. Through telemedicine, it may alert the patient diagnosis and the treatment plan. Aim of our work, it was to study the effect of practicing the telegeriatric on the health outcome of dementia patients and their caregivers as regards the patient outcome, caregiver stress, and caregiver satisfaction. Our study design, it was a descriptive study. It was follow up for 6 months. Sample size, totally 97 elderly patients. Our study setting, it was at our geriatric and gerontology department at outpatient clinic at Geriatric Hospital, Ain Shams University. The study period was conducted between February 2021 till February 2022. It was at the time, due to COVID pandemic, traditional regular in-person care wasn't available for dementia patient at our facility وتقريبا all over Egypt. فده كان العيادات الوحيدة اللي بتخدم our seniors during this period. In this chart, we will summarize the methodology at what we do during the study. We recruited our patient from geriatric clinic and ward patient. Inclusion criteria, it was elderly person more than 60 years, the primary caregiver diagnosed with dementia, has internet access, willing to use geriatric telemedicine services. Patient who has this criteria, it was excluded, especially patient who hasn't internet access. Our study actually has 2 arms, as we said, not only the patient, but also the caregiver and her family. Our patient went to totally detailed comprehensive geriatric assessment. It was doing with follow-up for 6 months, the follow-up was doing at every 2 months at first visit, second month, fourth month, and sixth month. After using التريجيرياتريك البيشنت في البدايه هنا البيشنت بتاعنا كنا بنريكروت وبنعمل له ديتيلد جيرياتريك كومبريهنسيف جيرياتريك اسسمنت. بالاسسمنت دي الفريكونسي اوف ديليريوم with psychotic manifestation وclinic visits وhome consultation, ER visit and hospital admission. These domains will be discussed later in details. Regards the caregiver, our caregiver stress assessment was done at first visit. Not only the questionnaire well done, but our session included healthcare education about the dementia symptoms and detailed explanation about the telegeriatric model. Caregiver satisfaction were assessed later. Our health education session also include polypharmacy assessment, caring how to care dementia patient, the next level I expected, and detailed expected symptoms for dementia. ودي الحقيقه فرقت معانا في المتابعات بعد كده، ان انا اقول للعيان في يوم من الايام هتحصل more decline in function, more decline in feeding, more decline في البيهيفير manifestation. فهو كونه expected ان في حاجه هتحصل دي بتخليه less horrible from the other manifestation. دي من المنصه بتاعتنا واللي كان التواصل من خلالها بيكون فيه تعليمات كامله ازاي يشترك بالمنصه، ومن خلالها بيدخل على عياده طب المسنين، ودي بعض الفيدباك اللي حصلنا عليها وقتها. Our results. Most of our patient was male. 41 was illiterate. والسكند percentage كانت ما بين primary وsecondary وuniversity education. Let's concentrate on dementia stage. Most of them were mild to moderate dementia. 13% was severe stage. Regarding mental state examination, most of them was mild to moderate. Here we take the baseline number of delirium, psychotic manifestation, clinic visit, home consultation, and ER visit, and hospital admission. Regarding caregiver, I considered about gender, age, education, with caregiver type. As we know, most of caregiver in Egypt it is family caregiver. هنختصر الجدول اكتر. It was found that the episodes of delirium it was significant reduction by the end of our study. كذلك الكلينيك visits والهوم consultation والER visit and hospital admission. It says the questionnaire of caregiver stress. The question here in detail. We found that this question is the most affected in our study. That the caregiver wasn't feeling angry as they usual before the study during being around their relative. كان بيبقى متضايق شايف ان والده او والدته لا مختلف عن الاخرين، لا مع فهمه للموضوع والسبورت خلال الستادي كان شايف ان بعد كده دي حاجه نورمال و I can deal with. Regarding caregiver satisfaction, there was significant results regarding they are satisfied the time spent and the video consultation saved the money, effort, and satisfied with the patient health. أهم سؤال كان بالنسبة لنا إن هو do you agree to pay for the service in the future؟ ومعظمهم قالوا تقريبا 74% كانوا موافقين إن هم ممكن يدفعوا this service later. Our conclusion for today is that telegeriatric follow-up model for dementia patient and their caregiver play an important role in the improvement of health outcome of dementia patients regarding the frequency of delirium episodes, psychotic manifestation episodes, and the need of home consultation and the number of ER. visits, clinic visit, and hospital admission, which decrease after the using the model. Telegeriatric follow-up model has positive effect on reduction of caregiver stress, which come back on improvement in their dementia patient care. The telegeriatrics and video consultation save time, effort, money, and most users agree to pay for these services in the future, besides being satisfied with the time spent with the physician and the doctor explanation for diagnosis, treatment during the video session. There are some characteristics associated with higher rate for discontinuation. كان في جزء كبير، عدد كبير فقد من العيان بتوعنا كان mainly for higher patient age, more advanced dementia stage, lower level of caregiver education, and higher caregiver stress score. Our recommendation: more frequent visits are recommended for dementia patient with lower mental state score and high caregiver stress score. Telemedicine services should be hand in hand in dedicated education program, and we نفتقد الجزء ده. Working on caregiver education regards dementia progression and how to deal with challenges will improve caregiver stress and quality of life of dementia patient. والنقطة دي الحقيقة فرقت كتير جدا معانا، خاصة وقت الكونسلتيشن البيشنت from rural area أول مرة يتكلموا مع جيرياتريك سبيشاليست مش فاهمين طبيعه المرض، يمكن اول مره نشخص فيها العيان بتاعه كان في الليت ستيج والبيهافير مانيفستيشن بتاعته. زيارات كتيره كنت ببقى مستنيه العيان قبل العيان او جاست وان اوف ذا كير جيفر، لا كنت بلاقي العيله كلها مستنيه بالاطفال. ات واز اميزنج الحقيقه، وكونسنتريتد ومستنيين الدكتور هيتكلم وبيكتبوا كل التعليمات، فبصراحه كانت تشالنجنج الحقيقه. Pre-visit preparation should be done to anticipate and manage patient expectation as well as ensure technology required. والنت في مصر يعني غني عن التعريف. From that technical problem we found. Our work already published. It's a great chance to announce about our geriatric virtual clinics. والحقيقه احنا عندنا مبادره دلوقتي ان في اول 100 كشف for free. It's available for the patient visiting our hospital and the outpatient clinic or admitted or any other elderly person all over Egypt. وأتمنى to share it between friends and family to get more benefits. Many thanks.
شكرا يا نورة.
الحقيقه ممكن اقول حاجه. احنا we all encourage الدكتور او physician researcher والبوليسي ميكرز telegeriatrics عامه not our responsibility as we said from the first of the day, but we should concentrate on how to put a telegeriatrics models or benefits for our elderly and to make sure how it was be applicable to provide a holistic care for our elderly.
احنا طبعا بنشكرك يا نورة على البرزنتيشن وعلى شغلك الحقيقه، وان هو انوفيتيف، ونشكر المشرفين بتوعك بصراحه. والحقيقه ان التيليجيرياتريك مهم جدا، لان هو مش بس في عيانين الدمنشا بس، لا، لان هو الحقيقه احنا لو حسبناها كده بحسبه بسيطه، العيان عشان يروح المستشفى اولا محتاج حد معاه علشان يساعده ان هو يروح. لو في عنده مشكله في الموبيليتي فهو محتاج عربيه اسعاف غالبا توديه وتجيبه، هتكلف الشيء الفلاني، وطبعا هياخد معاه الادويه بتاعته والانفستيجيشنز بتاعته والكلام ده كله. فلو ان احنا بنعمل ديجيتاليزيشن للسيرفيس دي والعيان يتقدم له الخدمه في مكانه، ده في حد ذاته يعني ايه، بيوفر وقت وبيوفر مجهود وبيحسن كمان الايكويتي اوف كير، لان حتى العيان اللي مش قادر يتحرك ده بتوصل له السيرفيس لغايه عنده. ومش عارفه انت ليه كروتينا يا نوره وانت بتقولي our work has been published. لا يا حبيبتي، افتخري بنفسك ان انت نشرتي في Q1 وحاجه يعني شغل محترم ونشرتي في مكان محترم، ف you should celebrate that. حد عنده اي اسئله للدكتوره نوره او دكتوره هبه؟ طيب شكرا جميعا.
شكرا دكتور.
this session. شكرا.